America's seniors had high hopes when Congress decided to add prescription drug coverage for Medicare beneficiaries, a so-called Medicare Part D. But once the Medicare prescription drug program began last January, it was off to a rocky start. Hello, I'm Walter Cronkite. In this program, we will take a close look at the key problems with the new Medicare drug program. More importantly, we will examine how those problems can be fixed.
When January 1st rolled around, it was total confusion.
It's complicated.
Confusing. Definitely confusing.
A key problem with the Medicare Part D program has been complexity.
I've had people who have come into the store with a 3/4 of a grocery sack full of Medicare Part D stuff, and they go, "Help, I can't figure this out. I don't understand."
In each state, there are 40 to 60 different prescription drug plans, and each one varies. It varies with regard to the premium, the deductible, the copayment, the coverage gaps, the lists of drugs that are covered, the restrictions on the drug availability, the drug prices, and finally the pharmacies.
I take about 9 prescriptions. Ruth takes about 13. Now, you have to look at a variety of plans to see which of the 22 are covered. This is apart from the consideration of how much is the premium, how much is the deductibility. But it took me 2 months of looking at this before I decided which way to go. And to this day, I'm not certain I made the right choice.
Once you sort through the many plans in your community and choose the one that might be best for you, you must remain in that plan for the entire year. The drug plan, however, can constantly change the drug prices that you must pay throughout the year. Because seniors' out-of-pocket costs in the program are very much affected by drug prices, most seniors want to know, is the program taking effective action to contain skyrocketing drug prices? The legislation that created Medicare drug benefit prevents the program from employing a cost-cutting approach that the Department of Veterans Affairs has used very effectively for many years. The VA successfully bargains with the pharmaceutical companies to get lower drug prices for America's veterans. But, unlike veterans, seniors will not benefit from the Medicare program's bargaining clout. That's because the Medicare law explicitly prohibits Medicare from negotiating with drug companies for lower prices. As a result, the price differences that veterans pay and what seniors pay are enormous.
The VA gets much cheaper prices than any of the private Medicare plans. Families USA conducted a study of the prices of the top 20 drugs prescribed for seniors. And for 19 of those 20 drugs, the prices obtained by the VA are much cheaper. And the median price difference is more than 48%. Let me give you 3 examples of the top 5 drugs prescribed for seniors. Plavix is the #1 drug prescribed for seniors. It's used to prevent stroke. The VA gets an annual price of $989. The cheapest price obtained by any of the private Medicare plans is $1,323. That's a 34% difference. Or Fosamax, which is used for osteoporosis. The VA annual price is $516. The lowest price obtained by a private Medicare plan is $728. That's a 41% difference. Or Protonix, which is used for gastric reflux. The VA price annually is $253. The lowest price obtained by a private Medicare plan is $1,111. That's a 339% difference.
Congress's decision to forbid Medicare from negotiating drug prices was a costly one. As a result, seniors will pay more in premiums, deductibles, co-payments, and other costs. It also was a costly one for America's taxpayers, who shoulder 3/4 of the drug program's costs.
The legislators and the congressmen abdicated their position on this program, and they allowed the pharmaceutical companies to write the program.
And the result is really tragic for today's seniors and tragic for future generations of taxpayers who will be paying the higher burden of taxes because drug prices are higher than they should be.
The pharmaceutical lobby got its way on this legislation. They've got enormous clout. They've got more than 600 lobbyists here in Washington, more than one lobbyist per member of Congress. They spend tens of millions of dollars in campaign contributions. And there is this revolving door where the people who played the key role in drafting this legislation are now representing the drug industry. The chairman of the committee in the House that wrote this bill is now the head of the pharmaceutical lobby, and the leader for the Bush administration on this legislation is now in a firm that represents the drug industry. From a senior's perspective, this is the worst kind of revolving door imaginable.
So, for seniors who do enroll in the program, what kind of drug coverage are they likely to get, and how much are they likely to pay for it? And is the coverage comprehensive? Every month throughout the year, seniors pay a premium to their health plan. Many plans require seniors to pay an annual deductible. After seniors pay the deductible, they must pay a portion of the costs of each prescription. But one thing is constant across virtually every plan. Once seniors' annual drug costs exceed $2,250, they fall into the so-called donut hole. Their drug coverage is interrupted. Their plans pay nothing, and seniors must pay the next $2,850 in drug expenses entirely out of their own pockets. It is only after seniors pay that next $2,850 that drug coverage resumes and is provided comprehensively for the rest of the year.
It's a little convoluted for me to understand why, if I'm not getting any help, I'm still paying for it.
Because first of all, you have to pay the government to get into Medicare Part D, and then you've got to pay for your drugs, and you've got to pay for the co-pays, and then falling into a donut hole.
That donut hole, we're going to have to spend $491 a month for her medicine, and that's coming out of savings. And, you know, I don't have $1 million in the bank, so it's going to go.
Both Marge and I will enter the donut hole. If you look at a calendar year, probably in the month of July, no later than August. And then we need to face much, much larger costs for our drugs.
Eventually, the only thing we'd be able to do is sell a house. That's the only other assets we got.
And they'll go without medications, there'll be tablet splitting, there'll be jumping doses, they'll just be going without their meds. And for a long-term health care provider like Medicare Part D not to take care of those people's long-term health care needs, that's a sin.
This coverage gap, the donut hole, it's not a one-time thing. It happens each and every year. And when a senior is in the donut hole, that senior has to pay 100% of all their drug costs. And while they're paying for 100% of their drug costs, they have to continue to pay the monthly premium. It's like going to a gas station and all of a sudden no gas is being pumped into your car, but the dollar sign keeps on rolling higher and higher.
It's ludicrous. You know, paying for something that you don't get any benefit from.
Every year, as the prices of drugs and the program's costs grow, the donut hole will get bigger and bigger. For example, the Congressional Budget Office projects that the $2,850 gap in coverage this year will grow to $5,066 in 7 years. A meaningful drug benefit remains a high priority for America's seniors. If the current program is going to truly meet seniors' needs, it is critical to focus on solutions to the program's problems.
One plan. I think one plan would make much more sense because, yes, it is now. You never know if there's a better plan out there.
They should be able to go to their pharmacy or a mail-order pharmacy and obtain all of their drugs for a given set premium or given set copay.
I mean, if you say you're going to charge them 80%, charge them 80%. If you're going to charge them 20%, charge them 20%. But I don't want to walk into the drugstore and find out that my plan doesn't cover A. I mean, prescription A, medicine A. And if I had another plan, maybe they would cover medicine A. That's ridiculous. I'm playing roulette with prescriptions.
If Congress had listened to the voice of the consumer, they would have written a very different bill. It would have had an option that was simple to understand through the Medicare program, not through private plans. It would have had the federal government negotiating deep discounts on behalf of Medicare beneficiaries instead of letting the marketplace set a price that may still be too high compared to what it should be.
This change also would have a significant impact on the cost of the program.
If Medicare ran this program, it would be much more cost-effective. Medicare, unlike private plans, does not have to pay for agents' fees, marketing and advertising, or profits. The private plans need to get all of those things. And if Medicare ran the program, they could do like the VA does, and they could bargain for cheaper prices. And with those enormous cost savings, we could eliminate this donut hole, these huge coverage gaps, which are unaffordable for America's seniors.
3 clear remedies for the program's continuing problems seem sensible. First, drug coverage should be provided directly through the Medicare program. That will eliminate the confusion resulting from dozens of very different private plans. Second, eliminate the prohibition that prevents Medicare from bargaining with the pharmaceutical companies for cheaper drug prices. And third, take the savings achieved through less expensive drug prices and use those savings to close the donut hole. But they can only be achieved if Congress chooses to make those changes.
I really do think that they had better stop politicizing this issue and understand that they're dealing with patients' lives.
Seniors have waited a long time for help in paying for their medicines. They need an effective Medicare drug program, a program that is simple to understand and affordable. We hope we have shed some light on the current problems of the Medicare drug program and how those problems can be fixed. Thank you for watching. I'm Walter Cronkite.